Thank you everybody for making it so late in the day. Just wondering, is Richard here still? He's not. I was actually one of the first cohorts of nursing students through the U2RH campus in Tasmania. I kind of wondered if I had a microchip in the back of my neck. Hopefully that's not the case. Oh, that's what that itch is. So firstly, I'd like to pay my respects to the Kalkadoon people, the traditional owners of the land that we meet today, and I'd like to acknowledge Indigenous elders past, present and emerging, particularly Anangu, Pilangaru and Maru people who have helped to keep me culturally and occasionally physically safe during my practices in remote Australia. And a quick thank you to Sabina for inviting me to speak today. I'm presenting some preliminary findings from my Masters in Public Health research project. It's a small project, but it's about a big issue. It's about a human right, the right to health. The right to health includes the right to access medications. It's about how the fragmented, assumptive, and discriminatory nature of legislation nationally means that these rights are not always realised to their full potential in very remote Australia. So everybody here is remotely interested, and my project is using the ASGS classification system of very remote. So you can see, just quickly, it's all that area that is yellow, which is most of the country. So before I get into the details of the project, I'd like to talk a little bit about how the project evolved. And I'd like to talk about dissonance. It's a lack of agreement. So across the country, there's a lack of agreement between the legislation that regulates how nurses work with medications. It's not only a lack of agreement between the legislation, at times there's conflicting areas between the nurses' code of conduct and how the context of remote nursing practice, what it demands of us as nurses. I know, having worked in a multitude of remote locations, I had a whole swathe of stories, and I was trying to decide which example should I use to demonstrate how confusing it can be for a nurse working in very remote Australia. Can I administer that medication in that state and I just move over the border? Can I do that? Can I fill up a dosette box? Can I follow evidence-based protocols and initiate and supply medications here? Because I could do it over there, but I've just changed states. I don't know. And I thought, jeepers, you know, one, if I'm confused and I've come through a remote health training pathway, imagine how a lot of the nurses out there who haven't come through that pathway feel. And what impact is this having on the population in Australia who have the worst health and the most difficulty in accessing services? Interestingly, and I kind of, you know, it's comforting for me, preliminary results are showing that I'm not the only nurse out there in very remote Australia who's confused. The greatest proportion of respondents were occasionally, always or often confused by the differences in the medicines and poisons legislation of the states in which they had worked. Why? You know, why is it okay for a profession to have to walk around daily in this state of confusion? I'm not going to talk too long about scope of practice, but I think Martha this morning, you know, highlighted some interesting things that they're finding in Canada. Nurses are enabled through their legislative system to work to the full extent of their practice. And certainly with the evolution of the nurse practitioner role in Australia, we're seeing more of that. However, not all remote areas are staffed by nurse practitioners. The majority of people out there are registered nurses. So the scope of practice of an individual is implicated, obviously, by the policies and procedures of the organisations in which they work, and the practice setting, by their own education, experience, knowledge and training, and by the health needs of the population with which they work. And we know what those health needs are in very remote Australia, and they're diverse and they're challenging and they're interesting and exciting to work with. And then, of course, in many instances, the limiting factor is the legislation and regulations that individually, each state or territory across Australia has its own set of medicines or poisons legislation, and they're different, and the terminology is not the same. Not everything's defined. In some pieces of legislation, what it means to prescribe is defined. In other pieces, it's not defined. What does supply mean? What does initiate mean? Is it even covered? What does rural and remote mean? Because even that's not consistent across the legislation in this nation. Lost in legislation, yes we are. I'd just like to highlight some positive things about the legislative system in Australia, and firstly the National Health Act, which back in the 1990s introduced the Section 100 amendments, which enable the free supply of medications for Aboriginal health services in remote areas, acknowledging that it can be really difficult for people to access supply there. However, the limiting factor is we've got this great supply of medications given to us free by the Commonwealth Government with a great intent. It's handed over to the states or territories. In some states, I might have a legal script for a patient in my hand and free supply of medication in the cupboard, and I cannot give it to the patient when they need it. Also, obviously, there's the Health Practitioner Regulation National Law, which, although it's a national law, it is enacted individually by each state or territory. Under that sit our Nurse Practitioner endorsement, the Midwife Scheduled Medicines endorsements, and the Rural and Isolated Practice Registered Nurse endorsement, and the Midwifery, Nursing and Midwifery Board Codes of Conduct and Practice Standards. Now, currently, it's a time for change. There's a real opportunity to influence and hopefully have some more positive directions in the future. The Nursing and Midwifery Board is looking at future models for non-medical prescribing across the diversity of practice, from nurse practitioner down to working under more supplementary models, which obviously means working to protocols, so not autonomous prescribing. But it's confusing, and if you want to know how really lost you can get in legislation, in developing the proposal for my project, I did a national comparative analysis, and this is just one of the two tables that I developed. And the top part, you can't see it in detail, and I'm not going to go through the detail, but it summarises what nurses can or can't do. Can we supply on a verbal order, on a written order? Can we administer? Can we initiate? What I'd like to highlight is the 3/4 of a page of sub-clauses, conditions, and variations between all the states and territories. There's a whole other page that looks exactly the same for how nurses work with immunisation, such a really important public health initiative, and it's still really complicated. Just touching on my project methodology, the primary research question is about the impact medicines and poisons legislation is having on health service delivery by registered nurses in very remote Australia. Nurse practitioners aren't excluded from participating in the project, but their data is going to be analysed separately. It's a mixed method project using a sequential explanatory design, so that basically means there's a quantitative survey conducted, and then qualitative data will come out of focus groups that are going to be used to help interpret the data, If there's enough interest here, there is the possibility I can run a focus group tomorrow, and it also gives people to have a bit more of an in-depth look at the data. There's also a systematic integrative review going on at the moment, looking at Australian literature about how nurses are working with medications and patient satisfaction, any safety issues that are coming up. And phase 2, as I mentioned, there's focus groups, and there's also a comparative analysis of the frequently authorised clinical protocols. So those of you who've been around remote for a while, you'll know that there's kind of the PCCM over here in Queensland. It's also utilised down in Victoria, and then Northern Territory, South Australia, and a lot of WA, but not all of WA, refer to the CARPA. New South Wales has its own little handbook called the Nurse Delegated Emergency Care Guidelines. So I'll be looking at all of those and the similarities and differences between them. So just a quick look at some of the preliminary results. The questionnaire is still open until the end of next week, but there's some really interesting trends coming out. So 56% of nurses felt that limitations placed on their practice caused them concern regarding the quality of care they can give. 67% were concerned about the timeliness of care they could provide. 50% felt that legislation was the biggest limiting factor in being able to provide a medication when in their opinion it would have been to the patient's benefit. And it's not uneducated, inexperienced nurses saying this. The mean number of years working in nursing practice of respondents so far is over 21 years. The majority of participants have postgraduate qualifications, and over 80% have done remote specific pharmacotherapeutic training of one sort or another. So from these preliminary results, we can see that medicines and poisons legislation, it's causing nurses confusion. It's causing them concern about the quality and timeliness of care they can provide. Now, timely access to medicines is a key component of our national medicines policy. We're talking about nurses working in environments when there aren't necessarily other health professionals at hand, and often not necessarily at the end of a phone or able to help practically in the way as the legislation suggests that they should be supported. So further analysis, once we've taken the final data cut, I'll actually be exploring the extent of roles that nurses are undertaking with regards to medication management and how that might vary across the states of Australia or organisations that people are working in. We'll also be taking a look at what legislative frameworks in the country seem to best support nursing practice as is demanded by the very remote context, and looking at organisational factors that also help support nurses. So that's a link to the questionnaire. If you've got colleagues out there working or who have worked as registered nurses in very remote Australia in the last 2 years, please share it with them. There's some postcards up the back with the links on them. And if you'd like more information about the project or you're involved in any advocacy work around nursing scopes of practice in relation to medications, that's my email contact, and I'm happy to share project results for advocacy efforts. That's all from me.